I know, yeah. Okay, thank you. First of all, I would like to thank Isam for the invitation. Unfortunately, I did not know Bob that well. I actually got to meet him this January 2022 for the first time. So we had a meeting together to talk about trying to do some collaborative work around lung cancer. But I'm still looking forward to that collaborative work. I thought we are in the radiomics zone. I come from nuclear medicine, so this is my background, and I consider that nuclear medicine today is multimodality. So we combine basically PET imaging with other modalities, whether that is MRI or CT, and this is what we are actually treating. So what we are doing is that we're doing a lot of work. We have been doing a lot of work on tumor characterization in nuclear medicine, which started with accurate segmentation of functional volumes. You see that our images don't look very, very good in terms of comparison with anatomical imaging such as MR or CT. We have a little bit more of a trouble actually determining our functional volume. So the whole adventure started about 20 years ago when we started working on automatically segmented functional volumes. And then I will show you how it developed into the radiomics program. So for us, the radiomics in nuclear medicine started with Isam's paper of 2009, which I think he was the first to actually work on PET feature-based approaches. And I had a PhD student that came to see me and he said, well, look at this. I mean, we can probably do something about it. And I said, no, it's PET images. You cannot really do something about that. So, knowing about PET imaging for some time, I thought, there is no way we can do something about improving overall images. So, but then again, I said, well, why not give it a try? So, we published as I said, we started with functional volumes. So the first thing we did was actually try to work automatically and try to determine automatically the functional volume. And what we actually seen, we started with esophageal cancer because, I come from Brittany, so people drink a lot. So there is a lot of a problem with esophageal cancer basically in our region. So that's why we had a very well characterized database of esophageal cancer patients. And we actually published this paper in 2011 that actually demonstrated that if you're purely looking at I don't know whether I can, if you're purely looking at the concentration of activity in the lesion, you cannot really separate groups of patients in terms of survival. But when you actually inject the information about the functional volume, then you can actually just see that you very nicely separate people with respect to prognostic power. So that was the first evidence that eventually we should go beyond just looking at the images and try to characterize a little bit more quantitatively in the information. And in the same year, the same student actually worked on intratumor heterogeneity in 2011 on the same database as the one that I show you here. And what he saw that what we demonstrated was that when you're actually looking at local entropy and when you're looking at regional texture analysis, you can actually separate response to treatment. So here we actually had 3 groups of patients, which is responders, partial responders, and complete responders. And while if you're just purely looking at the concentration of activity, you cannot really separate those groups of patients. When you actually try to look quantitatively in the numbers, then you can actually see that you can separate the groups and you can predict who's going to respond and who's not going to respond. So this is the beginning of the adventure for us with radiomics. And since then, over the past few years, we actually worked on different methodological aspects. We talked about reproducibility. In other words, if I scan the patient twice, would they actually be able to get the same numbers when I look at the texture analysis? And this is something that we looked at, and we saw that, particularly in the case of entropy, we can actually do as well as in terms of physiological reproducibility as we're actually doing with the concentration of activity that we're using routinely in the clinic. So this is something that we said that we could actually do it. One of the issues, we've seen a lot of work around predicting, and there's been a lot of debate in the last decade whether radiomics is basically a surrogate of volume measurements. okay, particularly in the case of PET, because you have quite a lot of fuzzy edges. So eventually a lot of people say, oh, well, you know, can you really do radiomics in PET? There is a lot of debate, and I think we put this debate to bed because in 2015, we actually pulled about a database of about 700 patients that we had with different characteristics in terms of tumor types and the rest of it. And we did a study where we actually looked at correlation between the volume, functional volume, and the heterogeneity. And what you see is true that up to a certain volume, you actually see volume effects. In other words, the entropy does not really bring you any complementary information. What heterogeneity gives you is basically volume information. But we see that above a certain size of lesions, there we start seeing some complementary information appearing, basically, that actually comes from the heterogeneity analysis. So at that time, we actually said, and from there onwards, we just said that anything above 10 cubic centimeters for volume in PET images, it does not really give you any heterogeneity information. What it gives you is basically volume information. Okay, so this is a debate that I think we actually had a few papers that have actually come up discussing whether we should go much higher, but you know, this is what we showed. And then we showed that at this level, when you actually get the complementary information in all of this database that we had, independent of the tumor type, we can actually find different groups in terms of survival probability with statistical significance. So when we get complementary information, then we can actually do something clinically about it. We discussed yesterday, for example, about what does radiomics analysis bring you more than doing some visual interpretation of images. So what we did in this particular study is that we actually took 3 observers and we asked them to actually classify tumors in terms of level of heterogeneity, 3 levels of heterogeneity. So the objective was to demonstrate that when you actually do this in a visual context, you cannot really do as well as you can actually do when you really get some numbers out of the images themselves. So this actually gave us also the feeling that eventually radiomics analysis on the FDG PET images does have something to bring to the field. And we worked on lung cancer, 120 non-small cell lung cancer patients in this particular study published in 2016, where we actually had, if you can see here, stage 1, you know, we can really separate it by just looking at the stage. But when you're looking at stage 2 or stage 3 disease, you can see that you cannot really separate groups of patients. And here what we did was we created a model based on 4 different parameters: stage, PET volume, and also heterogeneity from PET and CT. So this is manually basically derived. And this is the CT that was acquired with the PET CT, so it's not a CT specific exam. And what we saw is that we were capable of actually getting those curves over here separated in 3 distinct areas. So we could actually, with this analysis, we could actually find a group of patients that actually, irrespective of what type of treatment you will offer to them at the time, the treatments that were available, these will be the ones that will actually fail, okay? So these will probably the patients that will eventually benefit from an alternative therapeutic regime. And this is what we are actually validated. This was a retrospective analysis, and we have actually gone through to do a prospective analysis, and we found of new patients appearing in the clinic, and we found the same results basically. So this model holds. And of course, we spend a lot of time trying to say how radiomics analysis should actually be done in nuclear medicine. So we published a lot of work around responsible radiomics research. Now, we said what both did say and Paul, they said images are also data. In our case, we're actually saying the inverse. So data is also images. So, and what we want to say by that is that you need to really carefully look at and treat the images before you can actually get appropriate data out of those images. So it's true, images are data, but data are also images. So images need to be appropriately considered before you go through. And we published in, just came out basically in November, a guideline on radiomics and nuclear medicine between the 2 biggest association in the world, the European Association of Nuclear Medicine and the Society of Nuclear Medicine and Molecular Imaging guidelines on radiomics and nuclear medicine, where we're discussing all of these issues and how things should actually be done in nuclear medicine radiomics. So we're talking about machine learning and deep learning as well. So a few slides on that. Clearly, as we already seen, machine learning or deep learning can actually be used with for a lot of different applications. And what we did was we actually created a framework, a pipeline. We know that this is how basically we are going about trying to create predictive and prognostic models. We start with data acquisition and image reconstruction. We go a step of pre-processing. So we need to take care of the images and the way the images will actually be presented to the algorithm to extract the quantitative parameters. And then we go through extracting the parameters, what we call radiomics today, and basically then build the model. And I will try to show you at different levels where in nuclear medicine, in particular, artificial intelligence could actually have a role. There was a mention yesterday that we could actually, eventually, if we actually look at that pipeline, we could actually imagine, sorry, I'm going back. We could actually imagine that every single step of this pipeline could actually be taken over by deep learning, that's for sure. I can also try to sell that eventually we don't need to go through all of these steps and we can go straight from raw data to the model of the patient. It's a bit of a science fiction, but for the time being, but you know, we'll see whether we're actually going to be able to manage it and make it reality. So in the different individual steps, image reconstruction, for example, there is a lot of work that takes place today in nuclear medicine where what we're doing is we're starting with raw data that looks like that. And through the process of deep learning, we can actually produce reconstructed images. There's no mathematical process behind it. So what we're doing is we're just learning features from here and we try to match them with what's going on in the real images. And what we do is there are different flavors of this. And we are doing some work where what we do is we using the biggest problem with these approaches, or the ones that I showed just before, is that they need huge amounts of data to be able to actually train. Okay, and this is not very feasible in clinical practice. What we did was we tried to use pure UNet, so it's a very simple network to deal with. And what we're trying to do is we try to give it some very low quality images here in the upscaling to be able to actually help it to converge to the right position. So this is something that we're actually doing for CT, and we also did it for PET images. I will just show you some images. So just showing basically that this is the traditional approach where you need a lot of amount of data and a lot of optimization parameters. And this is what we're actually proposing. And this is the ground truth, which is based on classical iterative reconstruction algorithms. And we can do that in 3D as well. So we can actually produce, you probably know that today nuclear medicine goes towards total body imaging. So this is a study that actually uses total body data to reconstruct using artificial intelligence. Now, next step is clearly the segmentation. The segmentation is a bottleneck for us as it is for anybody else, I think, in the field of radiomics. I think we already debated, or we haven't debated, but we heard a lot of people saying that the image segmentation task has actually been solved in medical imaging. I would say that maybe it's one of the things that we could say that it could be first in clinical applications of deep learning. I'm not sure that it's totally been solved, but anyway, I will show you an example in nuclear medicine. So what we did was we actually developed a deep neural network. Nothing fancy, just a UNet basically, and we optimized it, and it actually won the Hector Challenge in 2020, 1 out of 20 algorithms basically, looking at head and neck cancer. But just show you an example. So we spend, I feel a bit sad because I spent about 20 years of my time developing appropriate segmentation algorithms for taking care of noise and image characteristics in PET images, okay? And basically what happened is that, you know, even with the best approaches, which are statistically proven to be the best, we still need to put a region of interest around the area that we would like to segment, because otherwise, you know, the algorithm will actually pick up natural uptake, for example, in the bladder. In the case of UNet, with a simple UNet, with very little data to train, we're talking about 20 datasets, not a huge amount of data basically to train, you can actually just produce that in an automatic fashion where it by itself, it actually knows that this is natural uptake and it does not include it in the segmentation process. So, and this is basically confirming what we've actually seen when we carried out the first MICAI challenge on PET tumor segmentation. And it showed that the CNN approach, it was actually doing a little bit better than the best approaches that we have actually been developing for the last 20 years in the field. So it shows that clearly deep learning has a role in segmentation of functional volumes. And the last one on feature extraction, and feature selection. I think you've probably seen this cartoon before. So we are into the area of, we're moving into this field, we're putting data in, and then we let the deep learning actually just give us the outcome. This is where we used to be, which is the handcrafted features through the learning machine and then the outcome. So we have a paradigm shift. So in other words, we're working directly from images themselves, and we need to probably take care of that. And we have a lot of variability. So this is a challenge within this context of trying to build deep networks directly from the images themselves. I would say variability because it comes from different machines. It comes also from different approaches of reconstructing the images or treating the images themselves. So we need to probably develop approaches that can actually do some harmonization work. We worked on that in the handcrafted features. So you see a multi-center trial with 3 different populations of patients being plotted in this graph. And if we actually do some homogeneity of the data, so we calibrate, somehow we normalize the distribution of the data, we can actually bring the 3 data sets together, okay? And then we can show that when we do not do this step, we are here, and you can see that you cannot really separate the groups of patients. And when you actually do the harmonization step in the data space, you can actually see that you start separating the groups in terms of probability of survival. So homogeneous, solving the problem of different types of data, different machines, different algorithms, I think it's something that is worthwhile. We showed that also in cervical cancer, in combining FTG with MR, where we actually looked at the sensitivity of predicting outcome. And if we do it within the center, we have a very nice IUC of 0.93. And when we actually do it on the second center without any harmonization on the data sets, what we see is that we're dropping to 86, okay, 0.86. And however, if we actually correct and harmonize the data, you can see that when we go to the center number 2 with the same model, we're actually obtaining the same numbers. So harmonization of the data is quite important when we would like to actually take one model from one center and put it and apply it on the next center. And this is something that just won basically last month the NM prize for most cited paper 2022 in the European Journal of Nuclear Medicine. So can we take it a step further? Because now we are talking about starting from images rather than handcrafted features. And I think this is important. What we are working on is trying to develop approaches for harmonizing images. And that will allow us to do image-to-image translation. So we start from a source image and we try to put it into a standardization image space. And clearly, we can actually do that for different purposes. So I will just show you some examples. This is one study where we're actually looking at the BRATS database, and you can see the variability that you actually have on the brain images here of the MR, which is caused because you use different protocols of acquisition, you're using different devices and the rest of it. So when you actually put all of that into a machine learning algorithm, you have a lot of variability that the machine algorithm is going to have to live with. Eventually, you can learn out of it, but we don't know how much data does it need to learn out of it. So what we do is we actually developing approaches that allow you to harmonize and make sure that, for example, all of these images are looking like this one. So you see here that these are the corresponding images that are coming here through the harmonization process. And what we have, I have one more slide. What we have is that we see that all of this variability actually goes away. And what we keep is we keep the right information that we then use into our model building. So in conclusion, clearly a very dynamic field, applied in all of the different steps. And I believe that we can replace all of these steps by a unified deep learning network framework overall. But we do need the larger and prospective multicentric trials to be able to actually demonstrate impact. So with that, I would like to thank you for your attention.
Thank you.